Sure.
Some people I know here, probably more than half I don't. Uh, this is the second in a four-part series where we're talking with nurse practitioners who work in the critical care transport industry. About 3 weeks ago, we had Keith Evans from Vanderbilt Life Flight, and listening and hearing his perspective was pretty interesting. And today we have Dave Holloway from the Cleveland Clinic Life Flight team. Dave and I know each other. 2008 is when it started, right? So
I'm around then.
Dave was a flight nurse, and then he transitioned to flight NP. And I'll let you kind of go over your story, Dave. But I have a lot of respect for Dave. I think one of the things that really stands out to me is I felt working with you, especially when you were a nurse practitioner, that not only did you know what to do, but because your experiences as an RN, like logistically, you kind of understood it all. And I don't know, I look back and it was like, when I saw your name on the schedule, that was a pretty good shift. So thanks for
Nice.
being here. Um, I will flip through the slides for you, Dave. And
Okay.
I left the questions. We kind of talked about this offline, that the PowerPoint's essentially the same as what it was.
Okay.
We may get through things at different topics and then we can just skip over some questions. But these are some questions that Tanner and I came up with that we either have or they've been asked to me. So I went over this on the last series, but really the reason I'm doing this series of interviews, having flown and having been a nurse practitioner in critical care transport, I felt like I had one of the best jobs and I still enjoy it in the world. And it's unfortunate to me that there's only a few programs who use nurse practitioners. So one of the motivating things behind what I'm doing now and what I'm working on in life is I truly feel that NPs bring a higher level of care. I think a lot of the things that actually flight nurses do in other programs are probably equivalent to what nurse practitioners do. And I feel they should get compensated for the decisions they make. So, what I hope to do is share with other programs, maybe not trade secrets, but ideas and ways to use nurse practitioners within their program to recoup some of the costs that come with employing nurse practitioners. So Dave is here to give the perspective from the Cleveland Clinic point of view. And Dave was a key author in this publication that was just released this month. It's called Nurse Practitioners in Critical Care Transport, where I didn't get Vanderbilt Life Flight's input on this, but Dave, some people from the Cleveland Clinic, and some people from Metro Life Flight, we put our brains together and we kind of said, okay, what do NPs bring to the table? And we really put that on paper. So I encourage those here to read the paper. It's a starting point. It's not the blueprint, but it's some things to consider when using nurse practitioners in critical care transport. So Dave, I'll kind of give the floor to you. And then when we stop talking, we'll move on to the next slide, and then this will be an open conversation. And for those who have questions, put them in the chat, and we either know we'll get to that at a later point, or we'll make sure your questions addressed during our discussion. So I'll give you the floor, Dave, and have at it.
Okay, great. Where should we start?
Why don't you tell everybody about your path? Kind of what you do now with the Cleveland Clinic and how you became to where you are right now.
Okay, sounds good. So Currently, my full-time role is a critical care transport NP for the Cleveland Clinic. I started my career around the year 2000 or so as an EMT, working EMS outside of Pittsburgh, and continued working in EMS roles during nursing school. My nursing career started with cardiac surgery ICU, some ICU float work, and then started working as a critical care transport nurse at the Cleveland Clinic while I was finishing NP school. And then I think it was late 2008, early 2009, transitioned to a nurse practitioner role at the Cleveland Clinic, doing transport full time, and did that for a couple years. I worked in the cardiac intensive care unit at the Cleveland Clinic as an NP for a couple years, while working in a PRN status at the transport program, and rejoined the transport program in a nurse practitioner management role. Did that for a few years and then relocated temporarily to North Carolina. I worked in the cardiothoracic ICU at Duke Hospital for a couple years, relocated back to Cleveland, and worked as an NP for our critical care house officer program, and then co-managed that program for a couple years before rejoining the critical care transport program full time.
All right, again, ask your questions via the chat. And we'll just start with the questions, Dave, and then we'll see where they take us.
Okay, sounds good. So my experience with critical care transport was first as when I was working EMS, and we would call for helicopters mostly for scene requests. So that was my first really exposure to flight nursing, critical care transport, and then worked as a critical care transport nurse for a year, as I already described, and that encompassed rotor, ground, and fixed wing. And then has worked in some capacity as a critical care transport nurse practitioner, either as a full-time clinician in a management role or in a PRN role, since about 2009.
Yeah, so the Cleveland Clinic, they started their program, it was 2007 or 2008, right?
I'm going to defer that to Dr. Reamer. I think he has the details on the historical perspective there, but I think the NPs started around 2007, 2008. Yeah.
Yeah, so you were hired on as one of the first batch of registered nurses, right? I know Dr. Reamer was, and then yourself, right?
I was hired at some point in the early days of the nursing program there. I'll be honest, I don't remember the exact chronological order.
Sure.
December 2006, the program was established, a year after the PETS program.
Yeah.
It started ground in May of 2007, and then shortly thereafter, air during that summer.
Perfect.
And then as far as critical care transport, Dave, you worked for the Cleveland Clinic transport team only,
Correct.
but then you worked for an EMS program.
Right. I mean, many years ago, I worked for a handful of EMS programs outside of Pittsburgh and Pennsylvania, and then I worked out in Ashtabula County during nursing school.
Gotcha. So you've been a nurse for how long, and then a nurse practitioner for how long? Roughly.
19 years or so as a nurse, and 15-ish years as a nurse practitioner.
Got it. I have some more questions, but they're later in the slides, so we'll get to them.
Okay.
Dave, do you specialize, and I know this, but do you specialize in family or acute care?
Sure. So I have an adult acute care nurse practitioner certification, and I don't have a family nurse practitioner certification, and I don't have a pediatric nurse practitioner certification of any variety.
Gotcha. So can you discuss the advantages, disadvantage of family nurse practitioners versus acute care nurse practitioners. And you and I have talked about this, and I think you and I were both kind of surprised when we heard that Vanderbilt used FNPs. And one of the things I need to say like now is what an FNP does in Tennessee may be very different than what FNP does in Ohio. In Ohio, generally speaking, family nurse practitioners and everybody else can chime in, but usually in Ohio, I've never heard of a FNP working in an ICU, potentially in an emergency department, but when they work in the emergency departments in Ohio, my experience has been they generally see more of the I guess less critical patients who would come through the emergency department. Dave, what are your thoughts as it relates to your program in Ohio? You know, we can only talk to Ohio as far as FNP versus ACNP.
Sure. So I think this is a kind of a complex question and complex topic. So, um, so the nurse practitioner practice is supposed to be described by the educational preparation, the clinical experiences during the educational preparation, and really what you're tested on for your national certification. So unfortunately, that doesn't really translate well into the nuances of day-to-day clinical practice. And I think that's really where the crux of this FNP versus acute care NP in hospitals, ICUs, and as we're discussing in the transport environment. Um, so I think that there's a lot more gray areas here than there are clear-cut advantages or disadvantages. So a lot of this, as we found out in our discussions with the Vanderbilt team, was that you know, state regulations in that area may allow for a little bit more flexibility for who can work where. So I think that's really kind of the undertone of all of this. So um, while I think it is possible for family nurse practitioners to work in hospitals and higher acuity settings, when I worked in the South, I routinely worked with family nurse practitioners in hospitals and in ICUs. So it can be done. I'm not saying that that's the right thing to do. But I think going back to the question in Ohio, there was a number of position statements that came out from the Ohio Board of Nurses and the Ohio Advanced Practice Nurses Association, I want to say around 2016, that kind of addressed this issue. There was a lot of debate. But in general, in Ohio, if you're going to practice in an intensive care unit or a high acuity setting, there's a general requirement for an acute care nurse practitioner certification. Some of this stemmed from our formulary for prescribing many years ago had quite a few restrictions for who could prescribe what, who couldn't prescribe certain medications that had to be initiated by a physician versus continued by a nurse practitioner. And within that formulary, there were restrictions for certain medications could only be ordered by acute care nurse practitioners. I think from a practical standpoint, I have not seen job postings for nurse practitioners in Ohio to work in intensive care units that allowed anything other than an acute care nurse practitioner certification. I think when it comes to the transport environment, I think you have to evaluate this in the context of what your program typically does. So great discussion with the Vanderbilt team and how they use their nurse practitioners. And it sounds like their nurse practitioners are more based from an emergency department role. And it sounds like from what I gleaned from that discussion, their program is more in the realm of frontline emergency type patient responses, quite a bit of scene responses, and they have a role taking intake calls in the emergency department. Is that kind of what you gathered, Dave?
Yeah, yeah.
So, so I think that in that kind of setting, that's probably fine. I don't think there's a clear-cut black and white or line in the sand of where an FNP preparation and role stops and an acute care starts, or vice versa. But I think you just have to evaluate that in the context of your program. Um, so I think just jumping to what we do, in our health system, we don't credential family nurse practitioners to work in intensive care units or at our critical care transport program. We do credential family nurse practitioners to function in outpatient settings, in the emergency departments. And we also have some family nurse practitioners, and I'm going to lump in adult nurse practitioners into this as well, who have primarily an outpatient role, but may round on hospitalized patients in a consultative role, but they're not the primary service for those patients.
Dave,
Yeah.
can we make one question or one point real fast? Because I think this may, we're talking about your health system specifically in pediatrics, just to get back to that, because I
Sure.
think the clinic's transport system may be a little bit different than other systems in that you are not qualified in pediatrics, but you're part of the adult team, right? Does the adult team do any pediatric transfers?
Great question. Yeah, that was kind of on my list for later, but yeah, we can go for that now. So in our program, we have split out an adult team and a pediatric neonatal specialty team. In general, the majority of our pediatric and neonatal interfacility transports are handled by our pediatric and neonatal team. And that's staffed by a pediatric specialized nurse and pediatric specialized paramedic and an EMT that operates the vehicle. Our adult team will take care of pediatric patients, and we practice that the nurse practitioners can manage anyone who's 14 years old and older. And if the patient is 13 years old or younger, we would either follow a limited set of protocols or use online medical direction to manage those patients. I should share that in our program, pediatrics is a very, very small part of what we do on the adult side and on the rotor side.
Okay, thank you.
Sure, that's a great point. Just to expand on that a little bit, I think if you have a program that is doing quite a bit of pediatrics with your primary response team, or your team really takes care of all patient populations as the frontline response, then you really have to evaluate what skill mix you want your nurse practitioners to have. And that may be a combination of acute care, adult acute care, and family. It may be a combination of adult acute care and pediatric acute care. Unfortunately, I don't think there's a clear-cut answer to how to approach this best.
Yeah, I agree, Dave. I think at the same time, for people who want to be NPs at the Cleveland Clinic Critical Care Transport Team, if they're looking, uh, they should choose the ACNP route, wouldn't you say?
I would agree with that. And I
Yeah.
think you also have to, globally for your career, what do you want to be doing for the long term? If in our area and for our health system, if you want to work primarily in the hospital as part of a primary service or in the intensive care units, you would need an adult acute care certification.
Yeah.
I
There's a
think,
lot. We
yeah,
know ACNPs can bill critical care time. I mean, I don't know, and that's a big part of the NP role. And I should know this. Maybe I'll look it up later. I don't know if FNPs can they bill critical care time? I just don't know.
Yes, because critical care time is not linked to a specialty or a certification. It's a concept of evaluation management. So I'm not aware of any restrictions globally, but there may be local, statewide, or even specific insurers that restrict that.
Got it. All right.
Not to harp on this too much, but since we're on this subject, so I think for our program, given that our frontline adult teams don't care for many children, it doesn't really make sense for us to require a second certification either as an FNP or a pediatric acute care nurse practitioner. But again, if you're at a program that is looking to implement NPs and you take care of a lot of children, that may make sense to look at a dual certification.
Yeah. Dave, can you speak about, you kind of did already, looking about your path and preparation to critical care transport, and then also maybe what you might recommend to somebody who wants to be an NP and CCT, and we'll talk specifically to the Cleveland Clinic and what you know, but
Sure.
if that's their goal, what's your recommendation? I guess start from RN, where do you go from an RN to become a flight nurse and then the transition to the NP role at your program?
Do you mean me specifically or just in general?
I guess tell your path and then maybe in general, and then your
Sure.
recommendation, for somebody who maybe is, I think if you start from an RN is good, becoming a flight nurse, and then maybe talk about too how you feel about, because you were a nurse, so was I, before becoming an NP, how you feel about the transition of going right to maybe ICU RN or ICU NP into the CCT world without that RN experience as a transport nurse.
Sure. So I think my path, I kind of already talked about it. I don't want to belabor that a whole lot, but I think some solid critical care RN experience. And I don't think that has to be at a particular hospital or with particular patient populations, but I think it should be high acuity and high functioning, high autonomy. Working in a setting where you have some shared decision making with the medical team, the expectations for how you function in that critical care role as a nurse should be high, and you should be comfortable making some decisions before you look to transfer or transition into a transport or flight role, because the large bulk of what you're going to be doing is making decisions and making judgments. I think that having some sort of EMS experience or exposure is helpful. I don't think it's absolutely mandatory. And then I think transitioning from a nurse role to an NP role in CCT, I think having some transport experience as a nurse is beneficial, but again, I don't think it's mandatory. We've had a number of our nurse practitioners who have come to us who were not transport nurses before, and they've been successful. I think looking back on my path now, if there had been an opportunity to work as an ICU nurse practitioner first, I think that would have been beneficial. But as we have a track record of many new grad NPs coming to our program with varied experience, and they've been successful without prior nurse practitioner experience. We also have a number of nurse practitioners who've come to us with experience and varied RN experience, plus minus EMS experience, and they've also been successful. So I don't think there's a clear-cut path here. I think it's really candidate specific and kind of the aggregate that they're bringing to the table.
Yeah. That's this is something that I debate too. I went your route from I went from RN right to ACNP, critical care transport. And I felt comfortable doing the role, you know, as a CCT NP. But like you, I feel for me, the ICU experience that I had um, was hugely helpful. What do you think about your like inpatient NP experience? What made that helpful in your mind?
Sure. So I think just to go back just for a second, when we were building the NP model at our program, circa 2007, 2008, 2009, um, there really there wasn't a large supply of acute care nurse practitioners in Northeast Ohio. It was still, for the most part, a growing and expanding role and concept. So we were using what was available, which was a group of new grad NPs who had really worked towards this as their goal, as their professional goal. Looking back on that, I'm not sure that that was the best path had we had experienced critical care nurse practitioners to do that. And if we were going to do that all over again today, I would say that I would look far more favorably on an experienced critical care nurse practitioner for what they bring to the table. I had worked as a nurse practitioner for a couple years at the transport program as a new grad, and then I worked in our cardiac intensive care unit as a nurse practitioner, and the amount of learning that takes place on a day-to-day basis and just patient exposure, interacting with consulting teams, rounding with the medical team, and the amount of decisions you make every day in the intensive care unit, personally, in my opinion, I think that that is more robust than what you do in a day-to-day role as a critical care transport NP.
Yeah. And much of this is going to depend where you work, right? The units you
Right,
work on.
right,
For me, you know, I felt procedurally the ICU experience was huge.
right,
You're learning under the guidance of people who've done things hundreds of times, you know, lines or whatnot.
right.
That said, in transport, how often do you put in a central line? Well, I don't know, but if you need it, it's uh it's interesting. Um,
Yeah, I think that's a great point, Dave. Procedures are important, but they're not everything. And looking back on it now, I think if we're going to say that procedural skill set is a core part of what we bring to the table, an experienced critical care nurse practitioner who's done 100 intubations and 250 central lines and 200 arterial lines, they're going to bring a much more robust uh, um, kind of background in procedures specifically. So when it comes time to do those in the transport environment, their comfort level with that is already established. They're simply doing it in a different environment.
yeah,
I think you make a good point. I mean, you know, I probably do a handful of central lines a year now in the transport environment, but when you need it, you need it. I
right.
think, same thing with intubations. I mean, we're not intubating every day. So if you come from a role where you did intubate every day or did put lines in every day, manage ventilators every day, and made some fairly high level critical care decisions every day, you're going to be more comfortable doing that in a different environment.
Yeah.
I wish, just kind of going to the next question, I wish that there was a way for critical care transport NPs in all programs to have a split role where they spent some of their time in an intensive care unit, um, or a similar practice environment, and some of their time in a transport role, because then I think you really get the best of both worlds, and you the skills and the experience that you're getting in the critical care the ICU, you can then take to the transport environment and vice versa. Unfortunately, just logistically, that doesn't work easily, particularly in large health systems. It's not always easy to split up an FTE, and then you kind of work for two different institutes. And we've looked at this many times over the years and just have never logistically been able to make it work.
Yeah. Hey, I don't know if you remind me of a good point, and I want to make sure we get to it. Can you tell us about some things nurse practitioners do on your team? And I'm just thinking EICU that are beyond just taking care of patients, like at Vanderbilt, where they were on call for COVID or they would do event medicine. Can you describe some things that like CCTNPs at the Cleveland Clinic do in addition to just critical care transport?
Sure. So many years ago, we were tasked with assisting to staff the inpatient rapid response team at our main campus, and have at times helped fill in for surge situations or staffing challenges um, in the past. And then currently we cover our, it's called e-hospital, some places call it EICU, but just a remote electronic monitoring center for critical care patients. And we supply the staffing for that at night.
Can you describe what happens there? So you're sitting there watching a bunch of patients in the ICU or the EER, or kind of what's the role of the NP when they're not flying in the e-hospital?
Sure. So for some of our hospitals at night, we become the primary service for the ICU patients and manage them either via telephone, video conference lines with the nursing staff. Some of the beds are hardwired for audiovisual. Some of them we use a robot basically that has audiovisual capabilities. And really, you can do everything to manage the patient remotely other than do procedures. For some of our hospitals, we're the first call for all the ICU needs. For some of the hospitals that have someone physically in-house, we serve as a backup role. Um, and then at night, our one of the e-hospital nurse practitioners serves as the primary triage and frontline medical control for the critical care transport program.
So if I'm an NP working at a regional hospital and I'm getting bombarded with patients, you would just help them out, like do admitting orders or kind of like be another set of eyes in case I'm not missing things? Is that how it works?
To an extent, sure. You can, we serve as a backup for admission orders, sometimes symptom management. Sometimes if they just want us to be another set of eyes to look at a patient, if the on-site provider is busy, maybe at a code or a rapid response up on one of the med surg floors, then we kind of assume that role as the frontline person for the ICU in their absence. So really, the possibilities and situations are endless for that role. Some of our facilities that don't have a critical care provider in-house at night, we will often be on the screen while the nursing staff might be doing a resuscitation. So you can lead a resuscitation remotely. Some of our facilities, the respiratory therapist is the airway management role at night. So it's fairly common for us to be on the screen, audiovisual link, while the respiratory therapist is managing an airway, maybe the nursing staff are doing some resuscitation. So that's another role that we fill.
Dave, do any of your NPs work in the ED or ICU regularly, or are they all in critical care transport?
Not as part of your scheduled role, but we do have some team members who have PRN roles in ERs or ICUs, and that's kind of a fluid state. But we don't restrict anybody from working anywhere else, but we don't require it either.
And then, in hearing you, I feel you do think that the ICU or the other experiences are beneficial. And I agree with you that if I were to set up my program and I was in charge of everything, not only would I like this as a clinician, but I think it brings the best of both worlds. I would have a month rotation, a month of transport, a month in the ICU or wherever you work, and just kind of go back and forth. And yeah.
Yeah, I agree. I think that that would be an ideal state. I think sometimes it's just challenging to work out the logistics of that.
Yeah, I think, and it would depend where you work, you know. I can say what the inpatient opens the doors to are multiple procedures. Like so many central lines, you don't even want to do them anymore because you're sick of them, right? A lot more airway opportunities and just a lot more decisions throughout the day with your multitude of patients that you're seeing. And the other thing that's been my experience is when you're questioning one of your decisions, you have a colleague or a specialist or a consult or an intensivist just to, you know, another resource there to ask questions and kind of dig deeper.
Yeah, agree.
All right, what qualities or characteristics make a strong APRN candidate in CCT, whether they are a new hire or an experienced NP?
Okay, sure. So I think splitting this out into kind of the clinical background and also the personality. So first we can talk about the clinical background, and I think you know, as I've said, you know, if they have some EMS experience, that is great. If they have some strong critical care nursing experience, I think that is really key. I think some exposure in an emergency department is also fine. But I think when you're evaluating a candidate, you have to really explore exactly what that experience was. We've interviewed a number of nursing candidates, I would say in the past couple years, who have no formal critical care experience as in terms of working in an intensive care unit, but have indicated that they feel that taking care of an ICU hold in an ER is a similar experience. And I'm not sure that that really translates one for one, but that certainly is something to consider when you're looking at someone's background nursing experience. Certainly, if they have some prior transport or flight experience, that may be helpful. But again, I think you have to really evaluate exactly what that experience was. So we have had some candidates who, when we interviewed them, they indicated that really they felt that when they were working as a nurse practitioner in the transport environment, it would essentially be working as a flight nurse, but they wouldn't have any protocols to follow. And that's really not the case. I mean, we're looking for someone who is willing to um, really provide an advanced level of thinking and judgment making. Um, so again, you just have to evaluate that in the context of exactly what their experience was. Certainly, if they have some procedural experience, maybe during NP school or as an experienced NP, that plays into it. If they are an experienced NP, exactly what was their experience. So if someone really just wrote notes all day long as kind of a glorified intern, that's really not going to translate well. But if an experienced nurse practitioner candidate maybe was functioning in um, a critical care role where they're the sole critical care provider in-house, um, maybe a critical care house coverage role where they are leading codes, but also the point of contact for all the critical care patients, where they're making a lot of decisions and have a lot of autonomy. That certainly is going to translate better, again, than someone who really has not had much autonomy, doesn't make many decisions, maybe has no procedural experience. So again, you just have to, I think, just drill down into exactly what those experiences were, um, um, to decide what type of candidate you're really looking for. So, but just to summarize, really, a strong background in critical care, perhaps some EMS experience, and ideally some robust critical care nurse practitioner experience. I think all of those make a strong candidate. And then flipping to kind of the personality side, I think it's critical that candidates are flexible, that they understand that they're going to be working in a role where there's a lot of ambiguity and there's not going to be set rules for everything that they're going to do. I would say if a candidate really depends on a policy for every decision they make, I don't know that they're going to function well in a transport environment. So, and those are just things you have to tease out when you interview people. Um, Someone that has their ego in check is critical. We, as we all know, a lot of times uh, flight and critical care transport is almost as much about the PR and outreach side of things as it is about the clinical management. So if you have someone who does not collaborate well, um, or has, maybe some opportunities to work on their communication, that's someone who is probably not going to work well either as part of your team or when they're interacting with referring hospitals or referring EMS agencies. So looking for someone who's a good collaborator, good communication skills, and is willing to, again, kind of get their ego in check. I think those are all crucial characteristics that a strong NP candidate brings to the table. I think lastly, if you can find someone who is comfortable being uncomfortable, I think that type of personality translates much better to a transport or flight role. Um, that is sometimes difficult to tease out in an interview. But again, if you can find somebody who is okay taking care of new patient populations, trying new things, is open to new experiences, even if it makes them uncomfortable, I think that really is the tip of the pyramid.
Uh, Aside from Vanderbilt and Metro Lifeline, I think there were one or two others that were posted last on the chat last time. Do you know of any other CCT programs that use APRNs in their crew configuration models?
So if I recall from the last event, there's a program in New Mexico, I think it's called Trans Aero, and then Nebraska Children's, as I understand, is using nurse practitioners as part of their crew configuration. I'm aware of a lot of programs that have crew members who have a nurse practitioner certification, but they are not functioning in that role. And those are probably innumerable.
Yeah.
Does anybody else on the call or in the chat know of any other programs that use NPs as part of their crew configuration?
If you know anybody who uses NPs as NPs, please put it in the chat.
Hey, Dave, why do you think that is? You think it's strictly finance? Why do you think that is? You think it's a matter of time?
Yeah, so yeah, Yankee, I forgot about your program. Sorry, I didn't mean to skip over that. The Vital One program is using nurse practitioners. That's great to see. But Dave, to your question, I think there's a lot of factors that go into. I think finance is one of them. I think there's some sticker shock that goes along with an NP salary. I think tradition plays a lot into it. I think also just local use of nurse practitioners in various areas is highly variable. So if there's a program in an area that just doesn't use nurse practitioners either at all in their hospitals or maybe not to their fullest extent, I think sometimes that paints a picture that nurse practitioners are not valuable in a transport role. So I think the other considerations for this are that sometimes when clinicians have completed their master's program or their doctorate program and they become nurse practitioners, some of them really aren't interested in working nights, weekends, holidays, 24-hour shifts. So I think the work-life balance plays into this a little bit. So maybe programs have evaluated this and found that they just couldn't find candidates and they abandoned it. So I think there's a lot that goes into this.
One of the points you brought up in our publication was the turnover rate for nurse practitioners. Can you share that? What the turnover rate is and how hard it is for you to get qualified candidates uh, into your program?
Sure.
And maybe
So
compare it to the flight nurses or flight paramedics, because that's kind of, that's one of the things that a program will need to consider is the training costs and how long am I going to retain that person?
sure, great question. So I don't have exact numbers in front of me, but I can say just our nurse practitioner turnover is very low. Out of a group of I think 18 or so, maybe one person a year, if that. And usually it's, they're relocating or they've had kids or a spouse is relocating. It's usually not because they are unhappy in the role. But we have a number of team members who have been with the program as nurse practitioners for 14, 15, 16 years and have never left. So yeah, I think that your point about the reduced attrition costs um, should be evaluated in this. Certainly our nursing and paramedic attrition is higher than our nurse practitioner attrition. So, you know, again, I don't have numbers right in front of me, but if you're paying a lot in training costs for nursing turnover, you may recoup that in a nurse practitioner model with very low turnover. Again, that's program specific, but that has been our experience.
In your program, Dave, and how important is pediatric experience and how can a candidate strengthen their resume when they apply for a job?
Sure, yeah. So again, good point. This is really program specific. In our particular program, it's important, but it's not a game changer. We have a lot of clinicians who come to us with no pediatric experience, and they're still successful. I think internal training can help bridge that gap. There's a number of courses that are available, like pediatric FCCS is a course that's out there. There's probably many others I'm just not thinking of right now that can kind of help bridge some of those gaps. Clinical rotations as part of your orientation can help bridge those gaps. And then just being willing to take care of some children in a transport role and just incrementally gain some competence that way. I think all is a way to bridge that gap. I think in our program, again, because we have a dedicated pediatric and neonatal team, and the volume of children on the adult side of things is very low, it would be difficult for us to require our candidates to have formal pediatric experience. And it may not be beneficial to them in the long term to work to gain that experience if they're planning to apply for our program.
Got it. And then I'm just am assuming that if you take care of anybody under 14, they're acting as an RN essentially. But for the most part, trauma excluded or you're called to an emergency, you'll have a separate pediatric team Now, let's say you were called, the pediatric team is out, and there's a 2-year-old has seizures sitting in a freestanding ED or whatnot. Would the adult team transport that patient?
In general, yes.
Got it.
Yeah. So again, our pediatric team handles the majority of our pediatric trips. We don't seem to have as much of a pediatric referral program as maybe some other programs do, or just other regions do. So I think that also keeps our volume of pediatric and neonatal requests very low. And it's really just patient specific. So if it's, maybe a child who's in a pediatric intensive care unit coming to our Children's Hospital pediatric intensive care unit for a congenital heart defect and they are critically ill, certainly that is something that we would push for the pediatric team to do. But Dave, I think your case of a child with seizures or maybe a respiratory virus, asthma, DKA, standard pediatric type calls, certainly the adult team can do those.
Yeah.
And then you brought up about, traumas. Certainly, we would expect that if our team is called to a scene that they can manage, pediatric trauma and frontline pediatric emergencies.
Yeah, and I think maybe one of the things I should have made clear earlier, I feel that the patients going to the Cleveland Clinic are some of the sickest of the sick. You like balloon pumps on your team weekly, right? I mean, and how often are you doing, say, an ECMO transport? Because I can't think of sicker patients than patients going to the Cleveland Clinic. It's not, certainly you do STEMIs and head bleeds and strokes and all the normal time sensitive stuff, aortic dissections, but you're getting a lot of really sick patients depending on mechanical devices too, correct?
Yeah, certainly we do, quite a bit of mechanical support. Again, I don't have numbers right in front of me. I would say on average weekly for balloon pumps, Impellas, ECMOs seem to kind of come and go. We might not do one for a couple weeks, and we had a day a couple weeks ago that I think we did 3 in 24 hours. So it's just highly variable. But I think even the patients who are not on some sort of mechanical support can also be pretty sick as well. So a large portion of our patient populations are critically ill adults who are already in an intensive care unit at what might be considered a tertiary center for another local area, who are coming to us for either an evaluation for mechanical support, evaluation for ECMO for respiratory failure, transplant evaluations, continuous dialysis for referring centers that don't offer that, inhaled pulmonary vasodilators. That's another a decent chunk of our patient population and referrals. So yes, you're correct. Fairly high acuity on the adult side, and
Yeah.
as you mentioned, mixed in some of the kind of run-of-the-mill STEMIs, strokes, things of that
Yeah.
nature.
I think that's one of the things too, is, not many patients make it on inhaled pulmonary vasodilators. And when they're stuck at a regional, they need probably some sort of other management offered at like an institution like the Cleveland Clinic. So you're transporting all that multiple drips, devices, inhaled pulmonary stuff. And, we talked about this on the last one with Keith. So maybe not for every program it makes sense to use an ACNP, but in my mind, these patients who were super sick, that's where the advantages really, come.
Sure. Yeah, and I think I put a little bit of thought into this, after hearing the discussion with Keith and the Vanderbilt team. I think that if you applied kind of a clinical scenario, if you're picking up maybe a patient who's having a STEMI at a freestanding ER or a critical access hospital, or even from a scene, um, you know, they get the typical STEMI meds, you fly them to maybe a cath lab at a community hospital, where they're going to get their cath for their STEMI. Certainly, I think that is very much within the realm of emergency care, and it's well, documented and practiced that an FNP can serve in that role. I mean, if an FNP is in the emergency department and a patient with a STEMI comes in, they may be the one to manage that patient. So certainly in that particular patient, an FNP, for example, could probably manage that patient well within their scope. But I think if, let's say 2 days later, that same patient who is now in shock on mechanical support, perhaps intubated, maybe a selection of vasoactive medications, maybe with invasive lines, who's going to be transferred from a community hospital to maybe a shock center, for example, for an ECMO evaluation. I think that patient now has clearly moved into the realm of where an acute care nurse practitioner would clearly be within their scope. And I don't think that the argument can be made that patient is now within the family nurse practitioner scope, if that makes sense. So I think it's really kind of on that continuum, and there's no, again, clear-cut line of which one's better.
Yeah.
Dave, can I ask you a quick question? Because there are
Yeah.
programs around here that do not, I shouldn't say around here, but just in general, that will not fly devices.
Sure.
You guys will fly devices. Will you
Correct.
fly ECMO?
Yes.
And then if the determination is made that they're ill or cannot fly or whatever, will you guys, the ACNP, go by ground with the devices?
Yes, we will. And not just devices, but any critically ill patient that we're unable to do by rotor. Depending on logistics, yes, the NPs will join the ground team and go and accompany that patient.
And very quickly, for people who may not be familiar, what do you guys fly?
For the next few months, Sikorsky S-76,
Okay,
transitioning into the H-145D3.
excellent. Thank you so much.
Now, that's a great question. Thanks, Tanner.
Yeah, so a comment in here from Yankee, who for those who don't know, we talked online earlier. He has a just a fixed wing critical care transport program, correct? He says, I would say most definitely the sickest adult patients I have transport is to the Cleveland clinics, maxed on pressors, 100% FiO2 and high PEEP. And I really do think those are the patients where having the provider on board, where there's no wiggle room, they're the sickest of the sick, is really warranted.
Yeah, I agree with that, Dave. I think certainly that's beneficial. I mean, I know there are a lot of programs that would move similar patients without a provider on board, and do so successfully. I think that it's difficult to write protocols for those types of patients. And I think that's, again, where a benefit that the NP brings is that you can manage that patient as needed without having to follow a written protocol or a guideline that may hold you to doing specific things. So again, I think that's even if it's not just the patient management, just the logistics of really following policies and following scope of practice laws. That's also helpful to have a provider on board.
Yeah. And a lot of the times, and we've both been on, everybody here who's flown, a lot of times the story you're given isn't what you get when you show up. So you I
Right.
think just figuring out right there,
Right.
Yeah.
Yeah. Agree.
Right. All right. So you kind of answered this. You did work as an RN or paramedic in CCT before becoming a CCTNP. Do you consider
Yes.
this important?
Yeah, I think certainly it is beneficial. You kind of get familiar with the environment, some of the logistics, some of the equipment, working with the team members. So certainly it's helpful, but again, as I said before, we've had a number of nurse practitioners who did not work for our program as nurses, and they've also been successful.
And is there a requirement at the Cleveland Clinic that so you can be hired on directly as an NP? You don't need 6 months or a year experience as an RN, correct?
Correct. We will hire nurse practitioners directly into transport, and they would function as a critical care transport nurse practitioner. That's correct.
Is it safe to say that all the nurse practitioners you've hired who did not have transport experience had a pretty significant degree of ICU or some sort of critical care background?
Yes, that's right. So they've all had, you know, a nice combination of strong critical care experience, some emergency experience. Many had EMS experience in prior lives. So um, that's really what we're looking for, and those are the candidates that we've found to be successful.
Yeah, you know, I teach a lot of new students now. Some of them only have a year or two of experience in an ICU. But would you say the likelihood of a new grad nurse practitioner would say 3 years experience as a ICU or RN is to be hired? And then if they're not going to get hired, what should they do to get hired on your team?
Sure. So if you're talking about all comers who have 3 years of nursing experience, who went to a nurse practitioner program, are they going to be hired on our team? I think the answer is maybe, but I think we're really going to evaluate exactly what that experience was. What were their clinical rotations during school? Um, you know, evaluating, you know, what is the likelihood that they're going to be successful in an unstructured environment. So maybe they would get hired. I think if that candidate came to us and we said, you know, you're not a good fit for right now, we would just tell them where they need to fill in the gaps. So is that maybe working in a different ICU, a different health system? Is it, you know, maybe getting some emergency room experience? Is it maybe getting some more exposure to just emergency responses? Is it getting some exposure to just making more clinical decisions? I think it would really depend on the candidate and you know where we found their opportunities to be before hiring them.
Dave, do you have your NPs follow any of the CAMES guidelines? So I think the CAMES guidelines say 3 years of ICU experience to fly. Also in 2025, the CFRN is going to be required. I'm not sure how you guys approach the CAMES guidelines. Just speaking of like limited experience.
Sure. So we do require all of our nurse practitioners to follow the CAMES nursing guidelines. You know, when we were first on our CAMES journey many years ago, and we were discussing with CAMES, because the NP role was considered an advanced practice RN role, they allowed the 3 years of nursing experience to um, meet the CAMES requirements. So I think what you're asking is, do we require our nurse practitioners to have 3 years of nurse practitioner experience? And the answer is no. And then the second part, I think, was about the CFRN. Yes, we are requiring all of our NPs to obtain the CFRN by, I think it's the end of next year. There's a date on it. I forget what it is, but yes, we are.
Oh, I maybe hit this a little bit, but you kind of told us about the emergency hospital and how NPs are used there. Is there any other like creative or unique ways that you use nurse practitioners aside from like clinical expertise that you can think of,
Sure.
or maybe some things that you've tried and it didn't work how they, you know, anticipated?
Sure. So just practically, our NPs basically run the program day to day on a frontline level. So we operate two rotor wing bases. We have three adult mobile intensive care units, a neonatal pediatric intensive care unit, a fixed wing program, and then we have our mobile stroke program, which the NPs really aren't involved in, but it is part of our program as a whole. Using those resources, we accomplish about 7,600 transports a year. So each mode is pretty busy. And our NPs really provide the frontline triaging, clinical management, and frontline medical control for all of those patients, exclusive of the mobile stroke unit. So they also provide the frontline logistical consults. It really kind of eliminates the need for us to have a large administrative team or team members that would otherwise deal with those issues. And then, as you mentioned, we also staff the e-hospital program as well. And then, other than the frontline clinical duties, the NPs do chart reviews, case review presentations, assist with processing metrics for the Gamut database, for example. And then many of our roles within our program that would usually be filled by another person in other programs are filled by NPs. So our safety program is run by an NP, our education program is run by an NP, our quality program is run by an NP, our PR and outreach is run by an NP, and our program director that was just named last week is a nurse practitioner. So that having our NPs fulfill additional roles allows us, again, to have a pretty lean administrative team. So we have a program director who is an NP. We have a nurse manager and an assistant nurse manager who manage our group of about 50 or 60 nurses and paramedics. And then we have a program manager who really handles our vendor relations and equipment. And then we have a reimbursement specialist who is shared with our Emergency Services Institute. And we have a program coordinator who functions in an administrative role. So again, having the NPs take on additional roles in addition to their clinical duties allows us to have what I think is a pretty small administrative team for the size of our program and the volume that we do.
Yeah.
Do you think that's a lot for the NPs, given how busy you guys are?
Sometimes, but what we do is we allocate non-clinical or administrative time to our NPs that take on additional roles. But I would say quite a bit of that workload can be done on a clinical shift, just in between trips, or especially in the winter in Northeast Ohio, weather does not cooperate to fly very much. So it's balanced out, I think.
Dave, what is your vision for ACNPs, your program, and critical care transport as a whole?
Sure. So, I think it would be great to see some growth of this model into other programs. It is great to see other programs using NPs. It's great to see what Vanderbilt's doing and some of the other programs we mentioned. I think for CCT as a whole, meaning the industry, I think it would be great to see, and this is again just my opinion, not my employer, but it would be great to see a reduction in kind of the for-profit culture and an increase in accountability for quality and safety that I think, as a lot of us have discussed offline, is certainly a challenge in this industry. So that would be my vision overall. I think moving towards critical care transport programs as part of integrated healthcare systems as opposed to a standalone service, I think certainly would support increased accountability again for quality and safety, potentially some reduced over triage. So that would be my hope. I don't think we're going to see anytime soon that nurse practitioner is a core team member. Again, for some of the challenges we talked about before, but it would be great to see more programs use NPs as NPs.
Yeah, I agree, Dave. I think, you go back 20 years or so, you became a flight nurse, and there weren't as many other opportunities once you were at the pinnacle of your career, right? And now
Right.
what I'm seeing is a lot of seasoned flight nurses, because they're driven people, right?
Right.
They want more. And it's unfortunate to me that, they further their education, and now there's only a limited number of opportunities for them. And my opinion is even senior flight nurses that are making high level decisions, like, I feel you need compensated for those decisions, and you bring another level of care than, say, your colleague who has a year of experience under their belt, So for
Sure.
me, it's kind of like maybe the minimums are lower. I don't know if that's the best way to put it, but I just want more opportunities for people who are passionate about transport, who are flight nurse practitioners. They want more. I'd like to see just more opportunities for them throughout the United States,
Yeah, agree.
Yeah.
Dave, you talked briefly about kind of that your team was involved in the rapid response team earlier on. Is that no longer a thing? And if it's not, is that something that you could see helping bridge that gap between inpatient clinical care and critical care transport? Having the team members rotate through rapid response for procedural skills, etc.
Sure. Yeah, great question. So this was really many, many years ago when there were a lot of transitions going on with our inpatient rapid response team. And we were approached to see if we could provide some supplemental staffing for that. And we did. And then again, as that transitioned, it went to a number of other different departments and is now staffed by a different institute. But certainly I could see both within our system and within other health systems that a critical care transport NP shares a lot of the same skill set as rapid response team leaders would, code team leaders. It's that episodic emergency critical care that they certainly are well positioned to um, um, provide that rapid response role, either as just supplemental staffing or to assume management of a rapid response program. It sounds like Vanderbilt did that at times a little bit during COVID. Their NPs provided some surge staffing, so yeah, that's definitely an opportunity.
I know you said you worked at Duke. I think Duke Lifelight covers that as well. If you have any information on that, I don't want to put you on the spot, but do you know if Duke did something similar?
I'm not sure. I did see something that the code and rapid response team falls under the Life Flight umbrella there now, but I really wasn't involved with that when I worked there, and I'm not familiar with those details.
Thank you.
I know the answer to this, but Dave, do CCTNPs make more money in your program than CCTRNs? Basically, are they compensated for their advanced degree and knowledge?
Yeah, so we have salary bands for our health system, and in general, um, uh, the nurse practitioner salary band is higher than a nursing salary band. Yes. Um, can't really get into those details of those numbers, but in general, yes.
Yeah.
Should I just go through the questions?
Sure.
So for the next question, so our CCTMPs are compensated on a tier system in our institution. So APNs or APRNs and physician assistants are on a tier system. There's 3 tiers. The CCTNPs are in the same pay band as the inpatient critical care ICU providers, advanced practice providers, and the emergency advanced practice providers. So the compensation is similar.
Gotcha.
Is that higher than other? Is that in the higher pay band?
It is in the highest pay band. There's our tiers are based on patient populations that you're seeing, hours worked, requirements for on-call, weekends, holidays, nights, all of those factors. So if you're an advanced practice provider who works Monday through Friday, outpatient, 9 to 5, no call, no weekends, no holidays, primary care, you would be in the lower pay band.
Yeah. And then looking for ideas, we've kind of talked about some, but any other ways, or how do CCT programs who use NPs offset the additional costs associated with employing those nurse practitioners?
Sure. Yeah, great question. So we'll talk about billing in a second, but I think how we offset these costs is, one, the low attrition. So we're not paying a lot in training costs. We have a lot of our team members who, again, have been NPs with our program for a long time. There's a lot of institutional knowledge, so I think there are efficiencies gained there with that experience. Again, with having our NPs take on additional roles within our program, I think that keeps our administrative team and administrative budget on the leaner side compared to similarly sized programs that might have a very large administrative team that does not function clinically. So I think we save some costs there. I think that, and again, while this is kind of difficult to articulate and quantify, we do see some efficiencies in terms of bed turnover, reducing lengths of time that beds are empty, and reduced workload on receiving teams because of the roles that our NPs fill. So again, our NPs are involved in the frontline triage. So that helps us use our ICU beds pretty efficiently, just in terms of turning things over, how quickly we can get patients moved around and into our system. And I think while this is a kind of a small specific example, our practice is to try to place an arterial line for our aortic emergency patients. So that takes us, maybe 5 minutes to do. But that reduces the workload of the receiving team, because now that receiving cardiology fellow or one of our nurse practitioner colleagues that works in our cardiac ICU, that's one less thing that they have to do to manage that patient, which, again, we don't have numbers to back this up, but anecdotally, we have a lot of feedback that is helpful, that helps improve efficiencies in the intensive care units. Sometimes our ability to de-escalate care during transport. So we frequently pick up patients who are on vasopressors and maybe non-invasive ventilation. We do work to try to wean those if appropriate. So it's not uncommon for us to pick up a patient on moderate or high dose vasopressors. We maybe give some fluid resuscitation, maybe some steroids, or whatnot, and we may be able to have that patient off of vasopressors by the time they get to the ICU. So again, we don't have numbers to back this up, but we have a lot of anecdotal feedback that, that is helping, reduce length of stay, reduce workload of our ICU teams. And then if we can move over to the billing side of things, Dave and a lot of people on the call, I think we've all had this question. We've gotten this question a lot. So you can have your NPs bill depending on their employment arrangement with the institution. and the relationship with who's billing for the transport. Those are, I don't want to say they're trade secrets, but those are things that I can't share publicly. But we do bill for the services that we provide. Not everything is actually billed to the patient. We have a reimbursement specialist who filters our charges to ensure that they are able to be billed, and then are then sent out for billing. What we bill out and what we actually are reimbursed, there is an astronomical gap between those two numbers. So even in places that have a really good payer mix, your average reimbursement is somewhere around 20% of what you bill out. Our payer mix is not that great. So ballpark figure, we get reimbursed about 10% of what we bill out. So that makes up for something, but it certainly does not offset dollar for dollar the cost difference between a nurse and a nurse practitioner. So I bring that up because again, we get a lot of questions about that, and a lot of people asked does the reimbursement from billing make up for the salary difference? And it certainly does not. So if you're at a program that's looking to employ NPs and you're looking for how you're going to justify that gap, billing is not going to do it. It's going to help, but it's certainly not going to bridge the whole gap.
Got it.
I think one thing that I took some notes and I'm just kind of going down my list. One thing that I think is helpful when you have NPs, particularly who are salaried, is that is a fixed cost, and you know that cost when you're budgeting. At times that can contrast with the cost of hourly employees like nurses and paramedics who, as we saw during COVID, there were a lot of bonuses, differentials being offered, premium pay, strategies of that nature to try to retain and recruit. And while certainly I'm not advocating that the NP should be undercompensated, but having a salaried NP, what that fixed cost is going to be for that budget period. As opposed to, again, an hourly employee where, yes, they have their baseline hourly wage, but when you factor in overtime, differentials, premium pay, recruitment retention bonuses, sometimes they are not a fixed cost, and it can make it difficult to budget for that.
Yeah, good point. I think we answered this. Are there differences in the scope of practice between CCTNPs and RN medics? Am I safe to say, well, I'll let you comment, but my take from talking to you is that basically NPs practice as an independent provider for the adults they're caring for?
In general, yes. So Ohio is a physician collaboration state. So we work with collaborating physicians. So it's not a complete independent practice scenario as it is in some other states, but functionally, yes, we do function as a licensed independent provider. So I think Keith articulated that as you can basically function as your own med control for the majority of patients. So that really is what sets us apart from the nurses and medics who would either need online medical direction or orders for a specific patient, or would need to follow a specific protocol to manage a patient. And then in terms of procedural scope, our nurse practitioners are credentialed for intubations, central lines, arterial lines, managing ventilators independently, and chest tubes. And we have emergency privileges for really anything you could think of, and that would include surgical airways, pericardiocentesis. Certainly our nurses and paramedics can, intubate But in our program, our nurses and paramedics don't put in lines, they don't put in chest tubes.
Now, with the nurses and paramedics, so would they call you? They would call a nurse practitioner before doing one of those, and not so much a collaborating. The NPs essentially are the med control then.
Yeah, so the NPs are the frontline med control for the overwhelming majority of our mobile ICU transports, where the NP is not physically present. So if our mobile ICU teams need to do something, they would call one of the on-duty nurse practitioners. If the on-duty nurse practitioner is not available, then they certainly could call the medical director on call. And that happens occasionally if both of the NPs who are on duty are on transports. And then if a situation arises where really a physician needs to be involved, certainly they can call the physician as well.
Yeah.
So if there's an example of that might be there's a major disagreement for a plan of care at a referring hospital. Maybe a patient clearly needs to be intubated and the referring physician is adamant against it. Sometimes the nurse practitioners can have a discussion with the referring physician, but sometimes it's best to just works better to have, physician to physician discussion.
Got it. What are some obstacles that hinder or limit the potential of the NP? This could include factors within your program, CCT as a whole, or even government operations.
Sure. So let me just look at my notes for that. So I think cost, we've already talked about it. Sometimes that sticker shock of the NP salary compared to the standard nursing salary. Certainly that's an obstacle. I mean, I don't want to try to pretend that it's not. Some other challenges specific to nurse practitioners is depending on the institution and institutional culture, sometimes nurse practitioners, and I'll lump other advanced practice providers into this bucket as well. Sometimes they kind of exist in this no man's land where they're really not nursing, they're not physicians, they're really not administration. So sometimes it can be difficult to advocate for the interests of nurse practitioners and other advanced practice providers, whether that be compensation, whether that be expanded scope of practice, and whatnot. So that can sometimes be a challenge if you're trying to expand the scope of your nurse practitioners or their practice skills, their patient populations. Certainly, there are some obstacles there that can be at the local or institutional level. I think while certainly we strive to find really high level candidates, I think the reality is that the people that are typically attracted to critical care transport and flight, as you said, are kind of at the pinnacle of their career, type A personalities, very motivated. Not all nurse practitioners function in a very high level role. So if you're at a facility or a program and you're trying to advocate for a nurse practitioner role, but the typical institutional experience of nurse practitioners is not a high level, robust role, that's going to be a difficult argument. So, you know, and I don't want this to sound negative by any means, but if at a certain institution, nurse practitioners are really just used to generate notes, or really non-clinical management, they don't do procedures, they don't have a lot of autonomy, it's going to be difficult to go to that institution and say, hey, you should put a nurse practitioner in your transport vehicle, because that institution is going to say, well, our nurse practitioners really don't do much in our hospital. Why would we put them on a transport vehicle? What's the benefit there? So I think that it's just those local and institutional or regional perceptions that also are an obstacle.
Yeah, I agree. My experience, having worked a couple different places, is, you know, much of this is at the top in the leadership of wherever the decisions are made. I've worked places where I've taught residents how to put in central lines, And I've worked at places where nurse practitioners don't do that,
Right.
and the latter, in my view, is just missing the boat, paying somebody, a physician, 3 times as much to do the same. I mean, it's a line, Dave. You know what I'm
Right.
saying? So
Right.
when I hear that as an NP, to me, that institution doesn't know how to use NPs effectively, so um, yeah, and unless that institution believes in the nurse practitioner role, it's probably not going to happen there.
Right.
Yeah. Oh, how do you keep, this is kind of a fun question, and I think there's only a couple more slides here,
Sure.
2 more actually, and then we'll get into questions. How do you keep up to date with the latest and advancements and protocols in CCT? And then what strategies do you use to maintain your composure and effectiveness in high stress, fast paced environments like CCT?
Sure. So in terms of keeping up to date, try to keep up with the latest literature. I think we all have um, individual strategies for how we do that. Sometimes it's just an email. It's, chain is started with some, a journal article that comes out, attending journal clubs. Um, I'm kind of surprised at actually how much is posted on Instagram that is clinically relevant. So sometimes social media is a source of learning new things and keeping up to date. I think within our institution, new practices and advancements are kind of passed down and kind of trickle their way down to us. So it's a lot of different ways to keep up. Um, and then strategies for composure and effectiveness. I think there's a number of centering techniques like box breathing, visualization, that sometimes if I know I'm going into a situation where I really need to be, ready to um, receive a lot of input and manage a stressful situation. Sometimes box breathing, kind of helps settle down the nerves a little bit. Um, and I think one strategy that's worked really well for me in a lot of different roles is reading the room and then leading the room. So, I think for people that do transport, you kind of arrive somewhere and you've got, a few seconds to really take in all of the input that's coming from that situation, process it quickly, make an assessment of the priorities and the factors and what is going on, and then figure out how you're going to lead that situation. So I think centering first and then having a plan of what you're going to do in those high stress situations works well for me.
Dave, can you quickly talk about your ongoing education, like annual competencies or quarterly training or something like that, just, along with keeping up with the literature?
Sure. So in our program, specifically for the NPs, we have to attend case review and cadaver lab at least once a year, but you can attend as many times a year as you want. Have to attend a safety day at least once a year, but you can attend as many times as you want, which goes over crew resource management, safety topics, um, um, vehicle safety training is a topic. And this year we've started a survivor series where we're having speakers come in who have survived critical care transport vehicle accidents to share their experiences. And then a competency day at least once a year, but many of our NPs proctor our competency days where team members come in and demonstrate clinical equipment competence in the context of clinical scenarios. We also attend a high-risk OB simulation lab and a difficult airway simulation lab. You have to attend once a year, but you can attend as many times as you want. And then we all have to maintain, kind of all the um, um, certifications, ATLS, and we have to maintain our nursing professional certification, which is going to be the CFRN. So those are some of the continuing education opportunities.
Got it. Anything else you want to say, Dave? And then I'll turn it over to the chat.
No, I don't
Tanner?
think so. Please, I hope everyone has some questions or experiences that they can share.
Okay, so far nothing in the chat, but if anybody has any questions, now's the time. I do have one question for you while people
Sure.
type maybe. So you kind of bounced around, but you always came back to CCT. And so for people out there considering it as a career, or for people out there who may be doing it now, what brought you back every time? And where do you get your satisfaction in the job?
Sure. Yeah, great question. So I think just that autonomy and ability to manage high acuity patients in an unstructured environment. You get the best of both worlds when you're functioning in a transport or flight environment. Certainly you get exposure to critically ill patients in the intensive care unit, but it's not the same as being able to work outside. And as part of a small team, impacting one patient, I think really is what drives me and what's brought me back every time.
I have one. Dave, who is the sickest patient you've ever transported? Like, what stands out? Like, oh my, I can't believe we just took this guy from here to there.
Let me think about that and I'll get back to you.
Yeah.
Can I answer? Dave, can I answer?
Sure, yeah. While you answer, I'm just gonna kind of read some of the chats.
So, first of all, Dave and Chris Manacci were the ones to inspire me to do flight nurse practitioner and to go through 10 years of college. But that was probably, I don't know, 2008 maybe. Dave came with Chris Manacci to a patient that they were in the middle of doing compressions in the room. They were doing CPR. And they transported this patient to the clinic. So I believe that was pretty up there from New York to the Cleveland Clinic. They came into the room and the team was like, the doctors, everyone that were there in the room were like, the Cleveland Clinic team is here. Just take over. We're backing up. Just tell us whatever you need.
Yeah.
So
I don't know. Dave, I remember doing multiple like balloon pump / ECMO, like a couple fixed wings, and for those who don't know Dave Holloway, he's like the cardiac device expert. The most knowledgeable person that I'm aware of in transport with cardiac devices. So you've moved patients on multiple ECMO patients and balloon pump and tandem heart and LVADs. And then you add on vents and pressors and all that other stuff.
I don't know if I'm an expert at it, but certainly have some experience with it. But thanks for that positive feedback, Dave. Yeah, I don't know that I could really put my finger on like the sickest patient, but certainly some of the device patients. Certainly, I've been involved in a number of trips where the patient needed, emergent surgical intervention at the referring facility, and the patient went to the OR, and we've taken them directly out of the operating room to kind of bridge them from kind of that frontline damage control surgery to a critical care resource at another hospital. So yeah, I can't really think of the sickest, but
Well, while you think, we do have one question in the chat.
sure.
This is a great question. I think it was Kyle provided it. I think he's one of the local, works for one of the local transport programs. And he asks, do you have any recommendations to new NPs slash soon to be new NPs, so call it new grads, who are interested in transport as a nurse practitioner? For those who are currently flying, do you think it's more beneficial to continue to fly as an RN and gain NP experience on the side, like in a part-time or PRN role in the ICU, or go straight to the ICU to get that NP experience? So basically, as a new grad NP, you go to the ICU, do you think you should still fly on the side, or, what are your thoughts?
Yeah,
And Kyle,
that's
if
great.
I ask that differently, then correct me, please.
Yeah, I think that's a great question. I think kind of looking back on my experience, but also what I've seen with other colleagues, I think the right thing to do, or the best thing to do if you're flying as a nurse, is to, if possible, continue to fly PRN as a nurse and work full-time in an intensive care unit. I think that's going to bring you up to speed quicker as a critical care nurse practitioner than flying predominantly and only working part-time or PRN as an NP. And I think if you're looking at doing transport as an NP down the road, personally, if I was hiring you, I would look more favorably on somebody who worked full-time as a nurse practitioner in the ICU and still flew PRN, or even gave up flying for a period of time to really work on those nurse practitioner skills and developing that role. So I think
Yeah,
oh, go ahead, Dave.
I have to say I agree with you 100%. I mean, you and I had both flown. I flew for, I don't know, 10 years, and then I went to the IC world and learned so much that
Yeah.
you just until you're there, you're like, wow, I missed all of this.
Yeah.
My feeling is with this particular person, you probably have the logistics down pat. Maybe you'll be a little rusty when you come back, but you'll get it back quickly. But the amount of decision making, procedures, make sure you work at the right ICU or where you're practicing at a high level. But in the long run, I think this person will be better off from that experience.
Yeah. Yeah, agree. So Kyle, I think practically if there's a way for you to find a full-time nurse practitioner role in an ICU and fly maybe 12 or 24 hours a week or a month or something like that, that's probably going to get you further than the other combinations, in my opinion.
Agree.
Got another question here. What factors do you think contribute to the low turnover of nurse practitioners in your program? And do the NPs that have worked in an ICU prior to transport, do they seem to prefer the transport role?
Sure. Great question. So I think there's a number of factors that go into this. One of the factors is that a lot of our team members, this was their career goal, and that keeps them in this role. This is what they've always wanted to do. They enjoy doing it. It keeps them in their role. I think through trial and error a little bit over the years, we figured out scheduling, work-life balance, kind of made small adjustments to the details of the role that has really kind of improved everyone's engagement and job satisfaction. And I think that keeps them in the role as well. I think as the compensation globally has gone up, and again, our compensation is tied to what our institution does, that certainly keeps people in this role. I think the ability for them to function with high autonomy and manage high acuity patients, certainly that plays into job satisfaction and engagement. So I think it's maybe a mixture of different factors for different people, but certainly there's a lot that goes into the low turnover. And then in terms of the NPs that have worked in the ICU prior to transport, they do seem to enjoy the transport role. And I think some of that comes from after you've worked in the ICU for a few years and, you kind of have your skills, kind of honed in, maybe you've plateaued a little bit in terms of, um, what else you can take away from that role. The transport role, at times, can be a little less stressful, or just stressful in a different way that fits people's personalities better. So, um, some of my jobs where I've been in the ICU, I'm frontline responsible for 8, 10, 12 unstable, critically ill patients. And that's a different level of stress, a different type of stress than when you're working in the transport environment and you just have one critically ill patient that you're responsible for. And I think that just goes down to people's individual preferences for why they like one versus the other.
Thank you, Catherine. I hope that answered your question. Forgive me if you hear the babies in the background. I have newborn twins, and they've been good all day. Does anybody else have any questions? If not, I do want to say, Dr. Konecki mentioned it earlier, that the paper that they just put out in Air Medical Journal talks about the role of nurse practitioners in critical care transport, and can almost serve as a blueprint for what they are doing and what they can do if you wanted to take that to your institution. It's a great read, a great paper. Congrats on putting that out. Again, it's available open access on Air Medical Journal right now. It's actually, if you go just to their website, it's right on the bottom bar. So shout out to them. Anybody else have any other questions in the chat?
No, I think that's it. Anything else you want to say, Dave? And then we can wrap this up.
So real fast, it's on Air Medical Journal. It's available open access on Air Medical Journal right now. You go to their website, it's right on the bottom. And shout out to Yankee for coming. Thank you. I follow you on LinkedIn. Your stuff is great.
I can put a link to the article.
Appreciate it. Thank you, Tanner.
Yeah, Dave, thanks for having me. Tanner, Dave, and Andy for arranging this. Hopefully this was helpful. And looking forward to the other events in this series.
Yeah. Let me go back to when they were.
It should be every 3 weeks. And guys, if you have questions, please reach out to us on Facebook. And the reason being is that if you got a question, somebody else probably has a similar question. And if you put it out to our Facebook, we can include it in other talks or try to get that information out there. I think we're all collectively trying to do, support the NP role in transport. And so if you have any questions, please reach out to us on Facebook, CWRU Flight and Critical Care Center. Dave just put the link to the article in the chat. Again, this will be recorded. It'll be available on YouTube. March 15th will be the next discussion with Dr. Robert Grabowski from Metro Life Flight, another local program.